Well, dear colleagues, it's my great pleasure to welcome you to another ESMO Guidelines real-world class webinar on small cell lung cancer. My name is Martin Reck. I'm coming from Northern Germany, and it's my great pleasure to welcome also the faculty, dear colleagues, in this webinar, Dr. Anja Ortega-Franco from the Christie's in UK, Professor Benjamin Besse, and Professor Jaafar Bennouna from France, who will work together with me on this webinar. Well, what are the objectives? Of course, we will talk about the CPGs. We will have a clinical case presentation for a selected topic, this case small cell lung cancer. We will review the case on the background of the small cell CPGs, which just have been updated and published. We also will discuss the case and the CPG recommendation on the question of implementation of our daily care. And lastly, you will have the opportunity to fulfill the questionnaire and to work on the learning objectives. And then we will have some closing remarks. So this is the program. I will make a brief introduction on the topic of small cell lung cancer. And then we will have Anja Ortega-Franco doing her case presentation. We will have a brief presentation of the small cell CPGs and the reflection of this case on the background of the small cell lung cancer CPGs by Benjamin Besse. And then we will have some consideration from Jaafar Bennouna related to the guideline implementation into our daily clinical practice. And at the end of the webinar, I would like to invite you to a hopefully very lively Q&A followed by some closing remarks. Well, now I would like to start with the introduction on the topic of small cell lung cancer, epidemiology, staging, molecular pathology. What do we know so far? Well, these are my disclosures. And we have seen in general a decrease in the incidence rates of small cell lung cancer in the past decades. Now it seems that we really have a steady state. We have approximately 15% small cell lung cancer cases compared to 85% non-small cell lung cancer related to all lung cancer. The majority of patients present with a metastatic disease, 70%, with a median overall survival somewhat between 6 and 12 months. And roughly 1/3 of the patients presents with a non-metastatic stage of disease. And there we can observe a median overall survival between 16 and 24 months. Similar to non-small cell lung cancer, small cell lung cancer is also a disease which correlates with age. So the majority of small cell lung cancer diagnoses occur in patients between 65 and 84 years. The clinical presentation is a strong association with smoking in the majority of our patients. We do see centrally located tumor with bulky mediastinal metastasis. We have an early metastatic spread, and the most frequent sites of metastasis are the brain, the lung, liver, bones, and the adrenal glands. We do observe a rapid tumor growth. On the other side, we have a high responsiveness to chemo and radiotherapy. Unfortunately, we have early treatment resistance, and the 5-year survival rate generally is below 5%. Well, looking on the ESMO CPG on small cell lung cancer, what do we require for the diagnostic workup? Well, first of all, we need the history and the clinical examination. We need a broad routine laboratory assessment. We need a CT scan from the thorax and the abdomen. In case of the suspicion of bone metastasis, at least we would require a bone scintigraphy, preferably a PET-CT scan. We are in need of a brain imaging, preferably by MRI of brain. Of course, we do need a tissue sample to determine the diagnosis of small cell lung cancer. And if we are considering a resection of the tumor, we also require the mediastinal staging and the functional workup of the patient. Well, pathology is done according to the WHO classification. We do have a number of epithelial and neuroendocrine markers available to confirm the diagnosis of small cell lung cancer also from a pathological side. And we have learned that small cell lung cancer also can develop from the transformation of EGF receptor mutant adenocarcinoma. And we do see this in approximately 3 to 10% of all EGF receptor mutant non-small cell lung cancer cases which progress after therapy with an EGF receptor TKA. The preferred staging method is the UICC classification, the TNM system, very similar to the NNCLC classification. However, when you look on old data, when you look on old manuscripts, in a number of these manuscripts, the old classification, the VSG classification is used, and this roughly separates the disease into two stages. Number one is limited stage, which classifies a non-metastatic small cell lung cancer, which is suitable for a combined chemoradiotherapy, or an extensive disease small cell lung cancer, which describes a tumor with distant metastasis where only systemic therapy is recommended as a treatment. And as mentioned before, the majority of our patients with small cell lung cancer do present with an extensive disease metastatic stage of small cell lung cancer. We also do have certain molecular marker which we do find in our patients with small cell lung cancer. Unfortunately, we do not really have an efficacious targeted therapies, but when we look on the molecular marker, we do see a high mutational load and genomic instability. Frequently, we have abnormalities like the 3p deletion, the TP53 mutation, RB1 abnormalities, a high BCL2 expression, or a SOX2 amplification. From a biological point of view, as mentioned, we do see this high rate of cellular proliferation, the rapid doubling time, the early metastasis, and the high sensitivity towards chemotherapy and radiotherapy. Looking on the treatment and from a clinical point of view, clearly this is the most important point to talk about. Well, after the establishment of platinum etoposide as a first-line chemotherapy, topotecan as a moderate effective second-line therapy, after establishment of thoracic radiotherapy together with PCI in limited disease patients, we haven't seen any major progress over decades, I have to say. This has changed in the early 2020s with the implementation of chemoimmunotherapy combinations as first-line treatment opportunities for patients with advanced small cell lung cancer. Having said this, I would like to thank you for your kind introduction, kind attention, and I would like to hand over to the clinical case presentation, which will follow now.
Hi, good afternoon. My name is Dr. Ortega-Franco. I am a medical oncologist working as clinical fellow at the Christie, and I will be presenting today this clinical case on small cell lung cancer. These are my disclosures. So our patient presented back in July 2020. She was a Caucasian female of 73 years old. She had a past medical history of hypertension, type 2 diabetes, COPD, and hyperthyroidism. She was not known to have history of autoimmune disease. Her drug history consisted on inhalers, statins, levothyroxine, antihypertensive medication, and metformin. She was an ex-smoker of 14 years. She had a 40-pack year history, no alcohol consumption, and she was fully independent for daily living activities before cancer diagnosis, and she had a good family support. She didn't have any history of cancer in her family, and when we saw her for the first time in clinic, she complained about worsening dyspnea of around 6 to 8 weeks. And at the moment of the visit, she was struggling to climb a flight of stairs or walk more than 10 to 20 meters. And she was starting to need some help for self-care. She also developed in the last couple of weeks dysphagia. She was starting to lose some weight and had a decrease in her appetite. She also had some chest pain in her left side, and she didn't have any signs of a paraneoplastic syndrome. On physical examination, she was clearly an ECOG 2, and her oxygen saturation was 91% resting on air, so quite low, and her respiratory rhythm was also increased at 20 per minute, and on physical examination, we could see that there was a decrease in the entry of the left lung. So this presentation was consistent with the findings we have in the CT scan. As you can see here, the scan performed in July showed a large mediastinal lymph nodes, a large subcarinal mass that was invading the left lung and also causing some compression and atelectasis of the lung. Unfortunately, she was also found to have a metastasis in the liver, and the imaging also showed metastasis in the left adrenal gland. So these are the investigations that we would usually perform to stage a patient with lung cancer. We also had a brain MRI that showed no metastases, and she underwent a bronchoscopy to sample the station 4R lymph node that showed malignant cells with a high nucleus to cytoplasm ratio, and the immunochemistry was positive for neuroendocrine markers as you would expect in a small cell lung cancer. Her lab results showed that she had a good organ function, but her LDH was raised, which again is very common in patients with small cell lung cancer. The MDT confirmed the diagnosis of a T4N3M1C extensive stage small cell lung cancer, and she was referred to oncology for palliative chemotherapy. So at that point in July 2020 in the UK, we had the option of doing carboplatin, etoposide, and atezolizumab for small cell lung cancer patients. However, this is restricted to ECOG 0 to 1, and because our patient was an ECOG 2, she received only carboplatin and etoposide chemotherapy. She received her first cycle on the 27th of July, and when we saw her on day 15 in clinic, actually she was feeling much better. She said that the breathing was now a grade 1, her dysphagia had completely resolved. We could see in the blood test how the LDH had normalized, and overall she was now an ECOG 1. This is the X-ray that we perform after one cycle. You can see how the mass in the left lung has improved, and also the mediastinum is looking better. So this is a very good response for only one cycle of chemotherapy, and we decided to look for other options of treatment for our patient. And at that point, we had the option of applying for an extended access program for carboplatin, etoposide with durvalumab. So within this scheme, patients that have an ECOG 2 at baseline, but clearly improve after one cycle of chemotherapy, had the option of receiving durvalumab from cycle 2. So we applied for the scheme, and we actually got it. And she started from cycle 2 with this combination on the 26th of August. And she received 3 cycles more up to cycle 4 on the 7th of October. She actually tolerated treatment very well with no significant immune-related adverse events. And we performed a CT scan to evaluate the response. And as you can see here, in the first row, we have the scans at baseline in July. And we have here the scans after 4 cycles in October. And you can see that there's been a clear response of the mediastinal lymph nodes, as well as the subcarinal mass that reduced by 69% in size. And most importantly, we see how the metastases also completely respond. The CT scan reported that the patient had new sclerotic bone metastases, but as you are aware, this is sometimes a treatment effect. Probably these metastases were occult at baseline, but after chemotherapy, they become apparent. So because our patient had this excellent response to chemotherapy, we decided to offer her consolidation radiotherapy to the left lung and prophylactic cranial radiation. Both were 20 grays in 5 fractions, and we can discuss later if you would have done the same, but our patient received this treatment from the 3rd to the 9th of November with good tolerance. She had nausea grade 2, fatigue grade 1, and some skin rash, but this is what you would expect from this type of radiotherapy. She started her maintenance durvalumab 4 weekly after the radiotherapy on the 25th of November. And the CT scan that was performed in January showed maintained partial response. So she continued on maintenance durvalumab until April 21, when a CT scan showed, unfortunately, that the tumor was progressing in the left lung, in the lymph nodes, and in the bone. She had her last cycle on the 17th of March 21. At that point, at the point of progression, she remained an ECOG 1, and the patient was very keen on trying other types of treatments. So we had the option at the Christie of a phase 1 trial with AMJ 757. This is a bispecific T-cell engager targeting DDL3 alone or in combination with pembrolizumab. So we started the screening assessments for the trial, and this included an MRI of the brain that unfortunately showed 2 small lesions in the cerebellum and another one in the parieto-occipital lobe. There was no surrounding edema, and the patient was completely asymptomatic. However, she was not eligible for the trial. At this point, we decided to line her up to the best treatment option that we had available, which was carboplatin as Dopocyte, because she had had an excellent response to the chemotherapy before, and she was more than 3 months treatment-free interval. She started her treatment in April and completed the treatment in July, again with very good tolerance to the treatment. And again, the scans show that the patient was still sensitive to platinum. This is the scans from April, and this is the one we have after finishing the chemotherapy in July. So at the moment we prepped this presentation, the brain MRI results for these patients were still pending. But our main questions for the patient was, what are the future steps? Should we treat this brain metastasis? Are we going to be able to line her up for any clinical trial, considering that she has small asymptomatic brain metastases? But as a final note, we recently got the results of this brain MRI that unfortunately show that she has multiple brain metastases. They are very small, and the patient remains asymptomatic, but still they are there, which are unfortunate news for this patient. So with this, I will finish my presentation. Thank you very much for your attention. I'm looking forward for the discussion.
It's my great pleasure now to introduce Professor Benjamin Besse, head of the Cancer Medicine Department at Gustave Roussy, Villejuif, France. And Benjamin will talk about the ESMO clinical practice guidelines for small cell lung cancer and the critical analysis of the case that we just have heard on the background of the ESMO CPGs.
We have seen a fantastic case of a patient with small cell lung cancer, and it's a good opportunity to review the recent ESMO clinical practice guidelines on small cell lung cancer. I'm Benjamin Besse. I'm professor of medical oncology at Gustave Roussy in Paris, France. Here are my disclosures. So let's review the epidemiology of small cell lung cancer. It's frequently referred as the leukemia of solid tumors, and by far small cell lung cancer is the most aggressive form of lung cancer. It's highly sensitive to chemotherapy or radiotherapy, but unfortunately in most of the cases it relapses, so the 5-year overall survival is poor, less than 10%. In Europe, the prevalence of small cell range from 1 to 5 per 10,000 people. It's equally prevalent in males and females, and the proportion of elderly patients rised from 23 to 44% in 35 years. In terms of epidemiology, again, there is no benefit to screen small cell lung cancer. As you can see, when you screen smokers and you find lesions, and that lesions after surgery is a small cell lung cancer, in 10% of the case, it is a lung cancer. In 10% of the case, it will be a small cell lung cancer. The best way to improve the survival of this population is to prevent smoking. In terms of diagnosis, diagnosis has to be done on morphology. So a small cell lung cancer is a high-grade neuroendocrine carcinoma with typical morphology, and Wu criteria should be used. There are very clear features of small cell, for example, the size of the cells or the granular nuclear chromatin. High rate of mitosis, extensive necrosis. Histology is preferred over cytology. In terms of diagnosis, you can find it pure or combined with non-small cell lung cancer or combined with large cell neuroendocrine carcinoma. In some cases, small cell lung cancer results from the transformation of an EGFR mutated adenocarcinoma. In most of the time, under the pressure of EGFR inhibitors. In that cases, it's frequently associated with the loss of LB1 and TP53 mutations. There are some immunohistochemistry that can help you to diagnose small cell lung cancer. TTF1 is not a diagnosis tool. It's frequently expressed, in fact, in mostly all the cases. CD56 is very frequently expressed by the tumor cells, less frequently synaptophysin and chromographin A. As you can see, PD-L1 is expressed in less than 20% of the cases, and Ki67 is very high because of the mitosis rate. So PD-L1 and TMB testing are not recommended, but because they are not predictive for immunotherapy in small cell. We have seen the workup performed on the patients in the clinical cases. Well, yes, we should use the TNM classification, the 8th edition, but in routine, a lot of people still use the very ancient classifications that divide only two stage, localized stage or diffused stage. Localized stage being those patients for which the tumor can be included in one field of radiotherapy. Regarding history of or clinical examination, it's very typical of a patient with cancer. Lab tests are also typical. Don't forget LDH, this is prognosis. In terms of imaging, CT scan of the chest and the abdomen is recommended. PET scan is optional. If you have a localized disease or a suspicion of bone mets, you should perform a bone scintigraphy or a PET scan. If this is a stage 1 to 3, a brain RMI is recommended. An RMI of the brain is also recommended if you face a stage 4 patients that is eligible for PCI, but for which you will not perform a PCI. If we look at the diagram of the ESMO recommendation and we look at the feature of our patient, this is a PS2 patient. PS2 patient, if the PS2 is related to the symptoms of the disease, so related to small cell, well, the author was really right. The combination of carboplatin and etoposide is the best choice. Why carboplatin? Because if you look in this meta-analysis over cisplatinum, you can see that for PS2 or more patients, carboplatin is better. Cisplatin might be a bit better for the younger patients with good performance status. Why etoposide? Because in Western countries, it's not better to give irinotecan combined with platinum salts. It's not the case in Asia, where irinotecan plus carboplatin is superior to etoposide and carboplatin. Recently, we had a major change in the treatment landscape of small cell lung cancer. Why? Because there is the rise of immunotherapy like everywhere in cancer. So this is why immunotherapy has been integrated to this diagram. So if the patient is PS0 or 1 with no contraindication for immunotherapy, you can add on the top of carboplatin and etoposide atezolizumab for 4 cycles and then atezolizumab maintenance. If you use etoposide and cisplatinum or carboplatin, you can add durvalumab for 4 cycles and then followed by maintenance durvalumab. If the patient has a contraindication to immunotherapy, it's the same regimen of chemotherapy or oral topotecan combined with carboplatin or irinotecan combined with carboplatin. As we said, if the PS2 is linked to the disease, you have to offer a doublet. But if the PS2 is related to comorbidities, well, you can choose best supportive care. If we look at the slides from Jordi Raymond, that review all the overall survival curves of trials that have tested chemoimmunotherapy versus chemotherapy. You can see in Empower 133 and Caspian that led to the approval of atezolizumab and durvalumab respectively, that roughly the immunotherapy adds 2 months on the overall survival, from 10 to 12 months overall survival. Here, the patient was PS2, so he was given chemotherapy only. But in fact, after one cycle, the symptoms of the disease regressed, and the performance status went from 2 to 1. And it was very logical to add on top of the chemo from cycle 2 some immunotherapy. If you look at the reaction trial, it compared chemotherapy to chemo plus immunotherapy, but immunotherapy was included at cycle 3 in all the patients that received 2 cycles of chemotherapy and had a benefit to these 2 cycles. So it seems that there is no loss of chance of a later introduction of immunotherapy to chemotherapy. So yes, I think that was the very good decision that the authors took. There is no biomarker predictive of the efficacy of immunotherapy. PD-L1 is not relevant. If you look at the Empower 133 curves, you can see that the benefit of atezo is seen also in PD-L1 negative patients, and tumor mutation and burden, TMB, assessed in the blood, did not lead clearly to some predictive value. In cases that we have seen, there was a very nice response. It's usually what you see with your patients treated with chemo and immunotherapy. What can you offer when there is a good response? Well, you can offer 2 different schemes. First of all, some radiotherapy, and that was offered to the patients, radiotherapy on the thorax, and a prophylactic canal irradiation for the patients that are younger than 75. And then they have started the maintenance durvalumab. Radiotherapy of the thorax do not increase the 1 year of overall survival. That was the primary endpoint of this trial that compared chemo alone or chemo followed by thoracic radiotherapy, but it does increase the 2-year overall survival. That is why this is an option. PCI is recommended 10 fraction, 25 grays, or 5 fraction, 20 grays for patients younger than 75 with a good performance status and a response after the combination of chemo after chemotherapy. Platinum, in terms of second-line treatment, you have to customize the treatment based on the treatment-free interval. 3 months is considered as a good threshold. So if your patients experience more than 3 months treatment-free interval, meaning that your last injection of chemotherapy was done more than 3 months ago, then you can re-challenge etoposide and carboplatin. If the disease is considered platinum resistance, meaning the relapse was during chemo or within 3 months after the end of the chemo, while if the patient has a poor performance status, you can choose lurbinectedin or best supportive care. If the performance status range from 0 to 2, you can use atopotecan, either IV or oral. You can use the combination CAV or lurbinectedin. In this randomized phase 2 in patients with sensitive small cell lung cancer that relapse after 1 line of etoposide and platinum salt, the patient was randomized between carboplatin and etoposide and topotecan. You can see that the combination increased by far the progression-free survival, even if the OS is similar. That leads to the recommendation in the ESMO recommendation. Lurbinectedin has been tested first of all in the phase 2 study, single arm. The overall response rate was 35%. Here again, the results were stratified according to the treatment-free interval. If the treatment-free interval was lower than 80 days, so 3 months, the overall survival was 22%. For the chemosensitive tumors, the response rate was 45%. In a very recent presented trial, Atalant, in this population of sensitive or refractory relapsed small cell lung cancer after one line of etoposide and platinum salt, the patients were randomized between lurbinectedin and doxorubicin or topotecan RCAD. As you can see, there is no difference between the experimental and the control arm in terms of overall survival, the primary endpoint. But doxorubicin is a toxic drug, and lurbinectedin was given as a lower dose compared to the previous trial of lurbinectedin single agent. If we move to the early stages, well, we have a very clear diagram, and we will go now more in depth for this diagram. Well, what is the role of surgery in small cell? Well, there is a small role of surgery. First of all, when you resect a solitary pulmonary nodule in 4 to 12%, it will be a small cell lung cancer. So you will find immediately this small cell lung cancer. If you perform on purpose surgery for stage 1 or 2, you have to perform an extensive pathological mediastinal staging. And adjuvant chemotherapy, in these cases, add a survival benefit as shown in the curve. So adjuvant chemo should be offered to a patient with PT1 or PT2, N0 or N1 or 0 disease. If you have an N2 invasion or an incomplete resection, you should offer adjuvant concurrent chemorad. If you give a concurrent chemorad, the chemotherapy regimen has to combine cisplatinum 60 to 80 milligram per meter square on day 1 and etoposide 100 to 120 milligram per meter square 3 days in a row for 4 cycles. Carboplatin is an option if cisplatin is contraindication. G-CSF is an option, and there is no role for consolidation immunotherapy. You can see in the curves the example of the negative trial that compare after chemorad of small cell lung cancer, a consolidation with ipilimumab and nivolumab versus placebo. What you can offer in terms of radiotherapy? Well, first of all, concurrent chemo and radiotherapy in good performance status is the standard treatment. In terms of recommended schedule for radiotherapy, the recommended schedule is 45 grays twice a day, 30 fraction. It has been compared in the CONVERT trial to the usual scheme with 66 grays in 33 once daily fraction. Both regimens, in fact, are used in clinic in routine. Thoracic radiotherapy should be initiated as early as possible. There is survival advantage of an early radiotherapy as shown with this meta-analysis. What if you have a patient with a poor performance status of a very high volume, so a dose at the organ risk that is too high? Radiotherapy should be postponed. So you can use a sequential chemorad in patients with poor performance status, comorbidities, or high disease volume. In the radiotherapy field, you have to consider the post-chemotherapy primary tumor volume, but the pre-chemotherapy nodal stations volume. PCI has to be considered for the patient with stage 3 small cell lung cancer in response after chemorad and with good performance status. It decreases the rate of brain mets at 3 years. For patients with stage 1 and 2 small cell lung cancer or elderly than 70, the role of PCI is not well defined. If you perform a PCI, the recommended PCI regimen is 25 grays in 10 fraction, and there is no benefit in terms of neurocognitive decline of hippocampal sparing PCI. Regarding follow-up, smoking cessation is mandatory. In terms of extensive stage, you can perform a CT scan each 2 to 3 months. When you have offered the patients a curative treatment, you should perform a CT scan of the chest and the abdomen each 6 months for 2 years, and then with longer interval. Because of the high risk of secondary primary, a yearly low-dose CT scan has to be considered even after a long follow-up. And finally, if you do not consider PCI, you should offer a close follow-up to the patient with a brain MRI performed each 3 months for 1 year and then each 6 months. With that, I thank you for your attention.
Well, for the last presentation, I would like to introduce Dr. Jaafar Bennouna from the Department of Medical Oncology, the Hospital Foch-sur-Risne in France. And he will talk about some considerations about the implementation of the ESMO CPGs into everyday clinical practice. And he will discuss these implementations in our daily care of our patients.
Hello, everybody, dear colleagues. I'm happy to participate to this ESMO Guidelines Real World series dedicated to small cell lung cancer. Today, I share with you data coming from our clinical practice for the management of metastatic small cell lung cancer. My links are described here. As discussed in the previous presentation, the optimal treatment is the triple association, etoposide plus carboplatin with atezolizumab or durvalumab. Following the ESMO guidelines, other therapeutic proposals determined by contraindication to IO or comorbidities can be applied. The purpose here is to evaluate how all those available options are distributed in our clinical practice. So, do we have patients receiving best supportive care only? What is the rate of patients with PS01 compared to PS2 or more in real life? The rate of patients effectively treated with platinum-based chemotherapy and also receiving thoracic radiotherapy consolidation or prophylactic cerebral irradiation. I didn't find in the literature real-world data for patients treated with IO, probably because this standard recommendation was too early from now. To make my words concrete, real data that I use are extracted from single-center studies, from 3 of them, and multicentric studies for 5. These all relate to retrospective cohorts, excepted from one from Germany. There is a paramount fact that a significant part of patients with advanced small cell lung cancer are treated with best supportive care only, from 14% in an expert Canadian center in Calgary to 40 or 45% in higher cohorts. Those 2 reports were from databases built from a country, England, for the first, or from a province of Canada, Alberta, from the second. The median overall survival with best supportive care only is between 1 and 2 months, emphasizing the aggressivity of this particular histology. These are characteristics of patients receiving chemotherapy and coming from cohorts generated by one center. Around 70% of patients have extensive small cell lung cancer with a median age 60 to 70 years. We may observe that males are not the majority in 2 of the 3 studies. In multicentric cohorts, the same patterns are reported. Please note that men represent between 50 and 60% of all cohorts. Again, median age is between 65 and 70 years, and obviously, almost all the patients are current or former smokers. Majority of patients had PS01, and almost all patients receiving chemotherapy were PS01 or 2. Come back to the most recent published trials, including IO, and compare characteristics of patients to retrospective cohorts. The median age is maybe little lower, from 62 to 64. The rate of women included in those trials is clearly lower than what we see in real life. They represent only 30% of patients included. Regarding the general conditions of the patients, they were all with PS01, which is not the case, of course, in real life. Taking all studies together, etoposide plus platinum is the preferred choice. The rate of non-platinum regimens represented in green is very low in all series, far less than 20%. The distribution between carboplatin and cisplatin is to the advantage of carboplatin. And this choice is often determined largely by factors like age and or PS. From the two series coming from Germany and Netherlands, patients treated with carboplatin are older and with a higher PS. In a center of excellence, the Valdebron Institute, 36% of patients were included in clinical trials. For those highly selected patients, the median overall survival was 15 months versus 8 months, with another ratio at 0.7. The trial in Germany evaluated that 23% of patients were considered as eligible for trials. And finally, as expected, PCI in metastatic disease was given in 20 to 40% of patients. Those patients were probably highly selected, corresponding to the best responder of chemo. This is maybe the most important slide of this presentation. What is the median overall survival of patients with small cell lung cancer treated with chemotherapy in real life? Overall, the median overall survival is below 10 months and closer to 8 months. When patients are selected, in example, patients who receive thoracic radiotherapy, in a similar way that patients included in clinical trials, you can observe that median OS is increased at 13.4 months. And this is confirmed by other data from the National Cancer Institute database, with a median overall survival of 12 months versus 8 months without thoracic radiotherapy, and one hospital from China showing the same advantage. We also have the rates of patients receiving second and third line. This is around 30 and 50% in second line and 10 to 20% in third line. And the benefit of platinum-based chemo reintroduction is clearly demonstrated in the majority of the cohorts. But again, this option is only for selected patients who have previously responded to etoposide plus platinum, with the disease progression occurring more than 3 months after the last injection of chemo. My perception in conclusion is that the ESMO algorithm for extensive small cell lung cancer is fully adapted to our clinical practice. Real-world data showed that there is a significant proportion of patients treated with best supportive care only, and this is correlated with age, PS, and comorbidities. In my knowledge, no real-world data are available with chemo plus immunotherapy. Carboplatin plus etoposide is the preferred choice in first line, eventually cisplatin for younger patients or better PS. But I think that in the future, with the association with IO, the use of etoposide plus carboplatin should increase because carboplatin prescription was the majority in the Caspian trial with durvalumab. Atezolizumab was validated with carboplatin, and finally, because carboplatin is a more comfortable drug for the patient. Overall survival is less than 10 months in real-world data, and the question will be to know what will be the median OS with carboplatin plus etoposide and IO in real life, and what will be the rate of patients treated with this optimal combo. Consolidation with thoracic radiotherapy improve median overall survival in real-world data, obviously for selected patients. Rate of PCI in extensive stage small cell lung cancer is between 20 to 40%. Regarding subsequent lines, a small proportion of patients is treated with chemo in second line and third line, 20 to 50% in second line, 10 to 20% in third line, and reinduction with platinum-based chemotherapy in selected patients improve OS, but we can say that after platinum failure, there is really an unmet need. Thank you for your attention.
So thank you for this brilliant presentations on small cell lung cancer, on talking about the ESMO CPG, on putting this into perspective, into clinical life. So we really have a difficult disease, and we have seen that we have some challenges in managing our patients, and we have got a cover of questions here. And my first question, I definitely also would like to thank Anya for her really very interesting case and putting everything together. And my first question is here from the audience for you. And it's the first one is very simple. So had the patient that you presented and brain staging at the initial diagnosis, did you perform an MRI or a CT of the brain before you started the treatment?
Yeah, so the patient had a baseline MRI that there were no metastases in the baseline. Yeah.
Okay, so at baseline, without brain metastasis, you confirmed the extensive disease, the metastatic stage of the disease with the liver metastasis. And I've got another question. So I think it was quite interesting to have this adoption of treatment according to the performance status. I think this was more primarily related to the reimbursement situation, but adding durvalumab in the situation when the patient improved, got a better performance status, this is an interesting approach, and definitely also added efficacy to the therapy. There's a question from a colleague about this additional radiotherapy of the lungs. So what has been your decision to offer the patient this additional therapy? Because when you look on the CT scan already, by the chemoimmunotherapy, this patient had a good controlled disease. It's a palliative situation. And number one is, what was the decision to add radiotherapy now to the concept of the durvalumab consolidation or maintenance therapy? And the second question has been, why didn't you put any radiotherapy on the side of the liver metastasis?
Yeah, that's actually an excellent question. So in the restaging scan after 4 cycles, there was a complete response of the metastatic disease, both in the liver and the adrenal gland. The only metastatic disease that we could see was in the bone, these neosclerotic changes that we saw after chemotherapy. So you're absolutely right that the pivotal trials for chemoimmunotherapy in small cell lung cancer did not allow radiotherapy. So I think that's a major question that we have, whether we should do radiotherapy. We did on the basis that the patient had a complete response of the metastatic disease, and she was still had some residual disease in the chest, and there's evidence to support this in terms of 2 years overall survival. But I completely agree that following the pivotal trials, you cannot actually say at the moment that radiotherapy to the chest is the recommended course of action. But I believe there's trials ongoing to address this.
Well, thank you for that. And I would like now to have some add-on question, but I'm not putting all questions on Anya. So I would like to address this to Benjamin. So you alluded also to the role of PCI, and when we look on PCI in patients with extensive disease, small cell lung cancer, that there are some conflicting data. We would say, well, there is a recommendation of PCI, at least this is something we would recommend to discuss with our patients. If this would be your patient, Benjamin, how would you discuss the opportunity of PCI versus a close control of the brain situation? What would be your approach and Gustav Rossi in that situation?
Well, first of all, we always discuss the opportunity with the patients. And although the threshold is 75 years old in the recommendation, I have to say that in our practice, we have the threshold of 70 years old, and we don't offer PCI beyond that. Remember that these patients are EV smokers, so they have usually cardiovascular comorbidities, and we know that when there are cardiovascular comorbidities, PCI toxicity might be increased. So it's and if the PCI is done, we always perform a new PCI just before the PCI to be sure that even after the course of chemotherapy, there is no brain mets. Definitively, brain RMI each 3 months is an alternative option. RMI is not a tool that is easily accessible in all the countries. This is the first point. And there are 2 randomized trials that are ongoing, one in the US, one in Europe with EORTC, that will address the question of the new question of PCI in the frame of the new standard of care that is chemo-IO, because let's remember that the trial was done before the chemo-IO area.
Thank you, Benjamin. And I think it's we have some recommendations that we make, but as you pointed out, in the end, it's an individual discussion which also has to take into account the individual patient. Jaafar, I have another question. It's also coming from the audience, and it's also about this patient, and it's about the number of chemotherapy or chemoimmunotherapy cycles. So conventionally, we are giving the patient 4 cycles. Do we have any data that an additional 2 cycles, so a therapy of 6 cycles would be of benefit for the patient?
So, like I said, in real world data, we don't have. What I've seen is not yet we don't have any data about IO plus chemo. So regarding the number of cycles, I think that 4 cycles of chemotherapy with etoposide plus carboplatin is the good option, and I'm not sure that it's necessary to go to 6 cycles, and maybe because if we can reinduce platinum-based chemotherapy at the first progression, it could be the best for the patient. So maybe I think that it's not necessary to go to 6 cycles compared to 4 cycles.
Yeah, to my knowledge, that there were some sites showing a small benefit, perhaps in progression-free survival, but we haven't seen anything relevant in overall survival. So I think the general recommendation of 4 cycles platinum-based chemotherapy plus immunotherapy, if feasible, is really good. Anya, there has been another question. So you considered this reinduction after the progression of the tumor. When you look on a reinduction in a potentially sensitive relapse, do you also consider the combination of carboplatin irinotecan instead of giving the primary schedule of platinum etoposide?
Sorry.
No, go. Sorry.
Yeah, unfortunately, in our setting, it's not available. So it's either topotecan or CAF or rechallenge with platinum etoposide. And I'm not sure whether in Western population is a treatment that we usually use.
Yeah. Benjamin, perhaps your opinion of the use of platinum irinotecan, is this, I think that the data are more presented for Asian populations. What's your opinion on that?
Yes, it's clearly superior in the Asian population. It's not in Western population, maybe because of the metabolism of the drug. Irinotecan and topotecan are topo-1 inhibitor. Usually they work a bit better when the disease is more is a bit less aggressive, let's say. So I have to say that I can use this drug, but there will be my preferred choice when the disease is, I know that the word is not appropriate usually for small cell, but I'd say indolent, or at least when the disease is not too aggressive. I say maybe the drug will have time to be active. Otherwise, I think it's better to use combination of chemo, and you can easily rechallenge etoposide and carboplatin in this population.
Benjamin, one additional question, if you allow, and I think this is a question which is coming from a number of colleagues. So, giving the data that we have seen for chemoimmunotherapy, we have been able to have some improvement in overall survival. We have seen some increase in the long-term survival rates, but from a medical point of view, I think there's still a need to improve the results. So what would be your expectations on the next steps? Are there any strategies to improve the survival outcomes in small cell lung cancer? What is your perspective on that question?
Well, let's be honest. The most effective treatment here is still chemotherapy. And you were discussing 4 to 6 cycles, but there is also the possibility to give 4 drugs instead of 2 drugs. And there is a survival advantage in the old studies. So now that it's immunochemo everywhere, it's only 4 cycles, maybe we should think in some strategy to escalate the dose of chemotherapy again. Because if you look, for example, the long-term survival of Caspian with durvalumab, the benefit concerns only 10% of the patients, in fact, with immunotherapy. What I see interesting is still these drugs that target DLL3, because DLL3 is really something that is expressed very frequently in more than 85% of the cases in small cell, and the new bispecific are really interesting. And there are also ADCs, antibody drug conjugate. ADCs, I call them smart chemo. It's only revised chemo, let's say, but there are some ADCs with very interesting activity on small cells. So I think chemo is not there, and we will have to revise both the immune compound, but also the chemo component in our strategy.
Yeah, and actually we are in desperate need of some potentially predictive markers. And as you nicely pointed out, the classical immunotherapy markers do not really work in small cell lung cancer, neither the PD-L1 expression nor the TMB. So there is definite some space for improvement. So I have received so many questions. We will not be able to cover all of them. I will close with 2 questions because they have been repeated several times. Number one, Jaafar, this is something for you from really the daily life. When we look on management of patients with limited disease small cell lung cancer, the radiotherapy applied twice daily is one of the preferred options that we do recommend for our patients. How feasible is this in clinical practice in tertiary centers? Do you have any data on that question?
So in my practice, and I think that it's the practice, at least in France, we use radiotherapy concomitantly to chemotherapy, but once daily. And of course, it's more practical. So I don't have, in my experience, the use of radiotherapy in small cell lung cancer twice daily.
Okay, so I think we are using it. It's feasible, but I think it's a bit dependent also to the area where you are working. So sometimes you have some local condition where this is really not feasible due to traveling times of the patient or whatever. So I think we have a recommended option that we also put in the CPGs, but we also have to face the reality in that question. Perhaps one last question, and I think this is for you, Benjamin, because I've seen this several times in the questions. What about the patient with EGF receptor mutated non-small cell lung cancer who transfers to small cell lung cancer? How do you treat these patients?
Well, it's really the small cell component that is that you have to treat. Even if these cells still express the EGFR mutation, they are sensitive to chemo mostly. So each time you see this component, you should stop the TKI, perform chemo radiotherapy if it's localized, chemo induce. And what I like to do is to do 6 cycles of chemo, sometime chemo IO, and then I re-challenge with the EGFR inhibitor. The only thing is that if you use durvalumab or atezolizumab with your chemo, don't re-challenge with osimertinib, because there is this interaction between immuno and osimertinib that can be fatal on the lung. So use a first or second generation inhibitor.
Thank you. And I think now I will have to come to the conclusion. There are so many questions remaining, so I think we are definitely in need of another webinar on small cell lung cancer. There's huge interest, and having said this, I would like to close this webinar. Perhaps if you can go to the next slide, I would like to thank all of you again for your great presentation, your contribution, Dr. Ortega-Franco, Benjamin Besse, and Jaafar Bennouna. This has been a great meeting. We have received so many questions. I would like to thank you also for your kind attention, and there will be a post-webinar questionnaire which you can find on the website, and I definitely would like to ask you to complete this questionnaire because we really need your feedback to improve our webinars. Having said this, have a great evening, and thank you for being with us on this small cell CPG ESMO webinar.